Chairman. On behalf of our team in Greece, I'd like to thank the organizing committee for inviting us to support the laparoscopic subtotal hysterectomy and this debate. We all know that this is a long-lasting question, but actually doesn't have an answer, which we'll try in the next 30 minutes to address all the existing data for both techniques and maybe have an interesting discussion after that. So going back to some history until the right, we're there. So this is a group of hospitals in Greece. They are a group of hospitals. It's one of the biggest units in Southeast Europe, with more than 17,000 deliveries and 30,000 operations on an annual basis. So the big debate is that there's a continuous controversy as to which procedure is best. And there are many arguments, both for pros and for cons of each procedure. Figures cannot lie, but liars can figure, and we've all seen that there are many big research that hasn't shown any evidence-based results. The big question that we should all ask in this room is what is actually best for our patient? Are we over-treating or under-treating our patient? And I think we should one time get a critical evaluation for that. So starting from abdominal hysterectomies, we still know that almost 80% worldwide, if not more, is still performed abdominally, and it's associated with increased morbidity, longer hospital stay, and so on. Same thing with vaginal hysterectomy. Although in many countries like France, it's very, very popular, there are some problems such as limited view, it requires two assistants, retraction, there's limited assessment if there's an extra pathology or adhesions, and it's high rate of pelvic hematoma. So, going back to our debate today, why remove the cervix? And that's a big question, especially in well-developed medical systems that there's good cervical screening when the problem is in the uterus. Why not do a procedure that's equal, if not better, and easy to perform? It has evidence-based lower rates of complication, much rapid recovery, it's a day procedure, and higher satisfaction rate. The opponents, of course, and I'm really looking forward to listening to the other Stefan of this meeting, is that there is a persistent risk of cervical disease, the question of cyclic bleeding, which is not actually complication. Complications refused for need future surgery and costs associated with the use of more equipment. Of course, there are many contraindications for the subtotal approach, such as history of cervical dysplasia of any form, and this is something that's non-compliant for this surgery. So going back to some data now, the research from Kirko and Ronrus followed a prospective cohort of 2,700 screened women that underwent subtotal hysterectomies, and they reported an incident of cervical cancer of 0.11%. Scott et al. On another follow-up study of 10 years reported a 0.2 rate of cervical carcinoma in women who underwent a total hysterectomy and had the cervical stamp. So the incidence of vaginal calf carcinoma after total hysterectomy is 0.17, and other research from Tucker and colleagues stated that the concern that cancer might develop in the cervical stump is no longer justifiable for routine use of total hysterectomy. The existing screening systems reduce the incidence of invasive breast cancer, and the risk of cervical cancer after subtotal hysterectomy is now less than 0.1%. Going back to some history, and this will show us what actually happened with cervical cancer, is that before World War II, virtually all the hysterectomies were performed as subtotals, and the reason for that were antibiotics, anesthetics, and risks having to do association with the surgery. After World War, anesthetics and antibiotics made more complicated procedures such as total hysterectomy feasible, and gradually all procedures were performed as total. That's how we have been trained in medical school to avoid cervical cancer. But what actually happened is that although everybody was trained with the fear of cervical cancer, in the 60s it was cancer number 3 among women, did it actually reduce deaths, the move from subtotal to total hysterectomy then? Borrowing this slide from Tom Lyons, you can actually see, although there was a huge change from subtotal hysterectomies in the 50s to total hysterectomies, which peaked in 1975. Nearly all procedures were done as total hysterectomies. The actual drop in cancer had to do with the introduction of the smear test in 1958. So we can see that the actual death rate from that had to do not with the conversion of procedures from subtotal to total, but with the actual introduction of the screening test by Papa Nicolau. So there's no evidence today to support the theory that the total hysterectomy was the main reason for reduced deaths, and there's substantial evidence that it was actually the smear test that continues still today to reduce deaths from cervical cancer. Some other paper from Harry Risch in 1988 proposed laparoscopic vaginal hysterectomy in order to reduce the known significant morbidity rates, and also substantial studies showed a decrease in the number of vaginal hysterectomies and gradual move to laparoscopic assisted or completely laparoscopic procedures. Once again, the data from Kiku showed that the supracervical hysterectomy compared with total hysterectomy, we're talking about abdominal cases, but the data is similar, had improved bladder function, had increased orgasmic frequency, overall decreased morbidity, and equal incidence of dysplasia findings post-hysterectomy. Other data from Simon showed significant shorter hospital stay, equivalent costs, and potential significant cost recoveries. The two people in the US and Europe that actually work a lot on supracervical hysterectomies, Tom Lyons and Professor John Arian, showed similar cases such as reduced morbidity, more rapid return to normal activities, decreased blood loss, rapid restoration of sexual function, same-day discharge, which is very important in the series by Professor Arian, and 3% cyclic bleeding that patients are actually informed for. Other papers from Juby show that the laparoscopic subtotal hysterectomy seems to be a better treatment for women with dysfunctional uterine bleeding. It has reduced a decreased long-term pain and overall improvement of the quality of life for patients. Once again, going back to what the patient needs is the indications for subtotal hysterectomy, menorrhagia resistant to traditional medical or ablative treatments, fibroids, endometriosis, and chronic PID. Of course, the hospital stay and the procedure is quicker depending on surgical skills, uterine size, presence of myomas, equipment, previous adhesions and cesarean sections, and so on. Major advantages of laparoscopic subtotal hysterectomy include no effect on sexual function, although there is no evidence base for that, decreased prolapse rate, because there is still, we keep the cervical ring, and we all know the importance of the cervical ring for the support of the pelvic floor, less complications, it's definitely an easier surgery and a day case procedure. And as we showed in our data before, the actual risk for cervical cancer is similar, and the cyclic bleeding is something that we have to inform our patients, and they don't actually really mind for that. So I'm going back to our series so far, of more than 1,100 cases. As you can see, we have a very high rate of day case procedures. The indications included previous cesarean section, endometriosis, fibroids, all the typical reasons for a hysterectomy. And all patients had initial failed medical treatment or failed Mirena cord or surgical treatments such as laser ablations, endometrial resection, and balloon ablation. The duration of the surgery can be from very short to very long time, depending on who is performing it and whether it's a training procedure or an easy uterus. Most of the procedures take very, very minimal surgical time, and most of the prolonged surgery time has to do with problems with enusilation. The blood loss seems to be very small. I'm not going to get into details for that because I think we have to discuss further about the procedure. And the follow-up of this series showed no late complications, one valve injury from oscillation, bladder injuries that are accepted at about 0.4% from previous cesarean sections, and a very, very good satisfactory rate from our patients. So, if we can eliminate the pathology and perform the same procedure with reduced morbidity, actually cost-effective, why move to total hysterectomy? This is a very quick video of our procedure, although I'm not going to play it all because I think it's a procedure that's known to everybody. Of course, patients that need total hysterectomy can be offered a total hysterectomy, and the big debate we get is why don't do it to everybody, but we feel that since we're treating a problem that has to do with the uterus, and since we lately feel that the cervical ring existence is very important for future prolapse problems, why not perform a procedure that will resolve our patients' problems without creating any new problems. Going back to data regarding the big cervical cancer question, there is no list of level 1 studies demonstrating the efficacy of treating gynecological pathology using the total hysterectomy. And there is no level 1 studies which have ever demonstrated that it's better to remove the cervix for cancer reasons than maintain it. Going back to the traditional Dicker's classic data, we can clearly see that the morbidity from the laparoscopic supracervical hysterectomy is very low and virtually there is no mortality. So in conclusion, choice is very important, and all patients undergoing gynecological procedures should be offered all of these procedures. Minimal invasive techniques are definitely more conservative approaches to tissue removal, and this enables the physicians to offer the patient more palliative means of dealing with their gynecological problems. The subtotal hysterectomy is a safe operation with a much lower complication rate, and all women should be informed of the availability of the procedure. They should be offered all the options and have a choice of this procedure if they are facing problems regarding the uterus. Of course, we need training and experience in order to get good results. Thank you very much.